It's really my pleasure to invite Professor A.Kalangos to give us his lecture, maybe the most important part for us cardiologists and our patients. It is surgery of congenital mitral valve.
Yes, and now we will continue with surgical options to fix this congenital mitral abnormalities. As you know, there is two surgical management options, replacement, and usually at this young age, the mechanical prosthesis is preferable. And then the best option, as Dr. Gavras mentioned, is to repair this congenital abnormalities. Because why? The benefits, the specific benefits are similar than adults. The left ventricular function is well preserved. There is no need for anticoagulation. And especially the durability in valve performance is better in pure mitral insufficiency. And then the mitral valve repair allows annular growth. And replacement is sometimes also technically impossible when little physical space exists in the left atrium. Now, surgically, there is, three groups of congenital mitral valves. The first one is the dysplastic leaflets, and in this subgroup of congenital mitral valves, there is a papillary muscle to commissure fusion. There is a parachute mitral valve, the hammock or arcade valve. And these abnormalities can be also part of the Schoen complex or hypoplastic left heart syndrome. The second one is the normal leaflet anatomy. And here we have, the prolapse of the anterior leaflet and or posterior leaflet. The anterior mitral clefts, the isolated anterior mitral clefts, it could be partial or complete. And then there is also some cases with primary annular dilation. And then the third group is the connective tissue disorders, which is part of the Marfan syndrome, Ehlers-Danlos, Williams, and mucopolysaccharidosis. Here, let me start with the first group. You see here the papillary muscle to commissure fusion or short chordae tendinea. Here you have the anterior papillary muscle, the posterior papillary muscle. The posterior leaflet is here. And you see very well the short chordae tendinea towards the anterior as well as the posterior papillary muscles here also. You see the short primary chordae tendinea, the anterior leaflet, and the posterior leaflet is here. Again, another image of the papillary muscle to commissure fusion. Here you have the papillary muscle, is the posterior papillary muscle completely fused to the leaflet tissue, especially to the ventricular surface of the posterior leaflet. Here we have, the parachute valve. As you see here, the single papillary muscle from which the primary anterior and posterior chordae are arising. Here you have the hammock valve. Here the specificity of this hammock valve, you don't have, very well formed papillary muscles, and usually regarding, the posterior, the attachment of the posterior leaflet is through, this short, multiple papillary muscles with short chordae tendinea, as well as sometimes, you have also the same morphological image on the anterior part of the hammock valve. It's very difficult really to repair the hammock valve. Here is a fibrous arcade from one papillary muscle to the other papillary muscle through the free edge of the anterior as well as of the posterior leaflet, forming an arcade. Now, what is the anatomical background of this first group, especially with the commissure to papillary muscle fusion, short chordate tendinea, parachute, hammock, and fibrous arcade, is they create usually predominantly mitral stenosis or mixed lesion, mitral regurgitation and plus mitral stenosis, and there is, lack of valvular tissue. In the second group, we have the congenital mitral regurgitation, and based on the classification of Carpentier, is defined as type 2 due to the elongated chordate tendinea, as you see here, the elongation of the primary chordate tendinea, as well as of the papillary muscle, creating a prolapse of the anterior leaflet. There is also, I see very often this congenital Barlow in children, and especially, in small children, is morphologically, there is an excess of tissue, and there is, this lobular appearance of the anterior as well as of the posterior leaflet, as you see here, the anterior leaflet, the posterior leaflet. And in my career, I had also 6 or 7 cases with congenital Barlow in neonates, and really the mortality is very high, especially in this age group. Here you have the isolated anterior mitral cleft. This one is a complete one, as you see here. Sometimes, you have also some partial mitral clefts. Especially, I saw some partial mitral clefts in women becoming increasing progressively, especially after pregnancy, by the increasing circulating volume. Now, what is the surgical strategy for this congenital mitral valves? The goal is to ensure the survival into adulthood by preserving a normal left ventricular function, a normal pulmonary artery pressure, and by preserving also a normal mitral size. And for this reason, the surgeon has to preserve the native valve if possible and reduce the number of reoperations. First, we have to agree that the valve tissue is not a no-touch zone. If really you would like to increase the feasibility of the congenital mitral valve, you have to be a little bit more aggressive than the adult group of patients. It means if you judge feasible and necessary, mandatory, you have to detach the posterior, or sometimes, what I am doing, the anterior leaflet from the native annulus in order to enhance vision of this on the subvalvular apparatus, to have, direct surgery and to apply, some techniques on the papillary muscles. And especially in the hammock lesion, you have to increase the mobility of the posterior leaflet by creating a new papillary muscle by detaching the posterior wall of the left ventricle with the chordal attachments and increasing, the mobility. This one is very effective, especially in the hammock lesions. And then sometimes, I'm detaching the anterior leaflet, check, the subvalvular apparatus in order to increase the feasibility of the effective commissurotomy. Now, how to correct the prolapse of the anterior and posterior leaflets? All these techniques are very well described by Carpentier. If there is what I do, if there is an elongation of the papillary muscle, I do a wedge resection according to the degree of prolapse. For example, if there is a prolapse of 3 millimeters, I remove a small piece of the papillary muscle of 3 millimeters and then I put, separate stitches, and by this way, you decrease the length of the elongated papillary muscle. Or, you can use the artificial cords. This one is also very good, especially, I prefer the use of artificial cords after the age of 5, because before the age of 5, unfortunately, sometimes, these artificial cords don't grow up according to the general growth of the child, and you can convert the regurgitant lesion into a stenotic one. What I do, one of the technical problem here is how, to calculate the specific length of the primary chordae. I use, I have this technique. I take, a tube. Based on the measurement I do, for a normal length primary cord, and then I split into 2 parts, and then, I put 2 parts of the artificial, of the Gore-Tex stitch, as you see here, and then, I tie the 2 halves of the stitch on the papillary muscle side, and then, as the tube is split, I remove, and then, it's fixed. This one is very intelligent. If there is, I believe, many surgeons here, really, it will facilitate, it will make easy your task. And then, again, the chordal transfer is a very good way to deal with this prolapse of the anterior as well as of the posterior leaflet. There is 2 options. You can transfer a secondary chordae to the prolapsing free edge, or you can detach a posterior primary cord, and you can transfer it to the prolapsing anterior free edge. The chordal shortening, again, described by Carpentier. You can create a trench into the papillary muscle, and then you can bury the excess length of the primary chorda into this trench, and then you close with separate stitches. Or, you can do the sliding plasty. For example, this part of the papillary muscle contains the elongated primary cords. You can split into 2 halves, and then you can slide the elongated part down according to the degree of prolapse. For example, if there is a prolapse of 2 millimeters or 3 millimeters, the distance between the tip and the first stitch should be 2 or 3 millimeters based on the degree, on the severity of the prolapse. Again, regarding, the dysplastic leaflets, here, there is restricted motion. Type 3 means restricted motion. And then, especially in these cases, for example, what I do in the hammock valves, I detach the posterior leaflet from the native annulus, from the posterior native annulus, and then I create, this trench. I elongate this multiple chordal attachments by detaching a piece of myocardium from the left posterior wall. You have to be very careful, because otherwise, you can also create a posterior cardiac rupture, left ventricular rupture, and this one is very critical. Really, this one should be done carefully. And then here, after achieving, this mobilization part of the posterior leaflet, you have to extend this posterior leaflet by using autologous pericardium. You will have a better zone of apposition, coaptation between 2 leaflets. Sometimes also in the hammock valve, I prefer to enlarge also the anterior leaflet, or sometimes, both of them. As I told you in the first group of patients, there is a lack of valvular tissue, and it's better, to try to compensate this lack of valvular tissue by adding some autologous pericardial patches at the anterior level or posterior level. Again, especially in the single papillary muscle, you have, to increase the intercostal space, as here, split the single papillary muscle, and then remove all this fibrous tissue from the intercostal space. If there is, in the short chordate tendinous syndrome, I do the same. Usually, you have two papillary muscles. Again, sometimes, I split also the two papillary muscles to elongate the shortened papillary, to shorten the shortened chordate tendinea and give more mobility on the anterior and posterior part of the mitral valve. And sometimes also you can do, this commissurotomy. You have to be very careful because sometimes when you do this commissurotomy and you don't have the chordal support, you can create commissural leaks. Sometimes we have, this valvular tuck tissue, especially I see this one in hammock valve, and then, you have also to remove carefully this valvular tuck, contributing to the stenotic effect of the hammock valve. And then again, you can split the anterior or posterior papillary muscle to give more mobility to the anterior and posterior leaflet. Now, there is an important issue. If you need to do an annuloplasty in this congenital mitral valve surgery, the rationale of it is to maintain the relationship of valve tissue area and surface of the mitral orifice in systole. And then the other big issue, especially in pediatric population, is the annuloplasty must allow for growth. The indication, I believe, is mandatory for all mitral regurgitation cases and in some mitral stenosis. For example, when you do commissurotomy and you don't have enough commissural cords, then you have to put a mitral ring in order to reinforce the coaptation zone in both commissural areas. What are the surgical options of this annuloplasty is to use a pericardial or Gore-Tex strip for one trigon from the anterior trigon to the posterior trigon, as you see here, sutured by interrupted U stitches. Or sometimes, the morphology of the posterior native annulus can be a little bit deformed, and then, especially in those cases, you can manage by some pledget, by multiple strips of Gore-Tex or autologous pericardium. And then there is, the other technique described by Pinet and Gerbaudet, doing, from the anterior trigon to the posterior trigon to reduce the posterior native annulus, and then reinforce by a autologous pericardial strip in order to avoid the redilatation of this mitral orifice. There was another one which was described by Kay and Wooler, is to plicate the anterior as well as the posterior commissures with this pledget reinforced stitches. I don't like this one because then the posterior part of the annulus can be at the origin of the redilatation of the native annulus. And then, usually when you use at this age this kind of pledgets, you can predispose the child to develop some calcification. And really, I had terrible calcifications after this Kay Wooler commissurotomy, condemning the feasibility of a re-repair surgery. And for that reason, it's better, to use different other annuloplasty techniques. And then there is the biodegradable ring. We started 20 years ago, and we had a lot of clinical cases with beautiful mid-term and long-term results. But unfortunately, the pediatric population there is few cases, and for it is in the industry condemned, the development of this biodegradable ring, because financially, the pediatric market is not promoting these companies. Again, if you would like, you can use also a biodegradable ring, especially what I do in neonates with congenital mitral abnormalities. Again, I start from the anterior trigon to the posterior trigon with the same biodegradable, is usually PDS suture material, and tying the two halves of this Gore-Tex suture at the middle of the posterior annulus. Or sometimes, in bigger children, if you would like to use a traditional rings above 26, because as you know, in the conventional rings, there is no pediatric sizes, you can enlarge the posterior or sometimes the anterior leaflet, which will allow you to implant at least the smallest traditional ring, 24, or is better, to implant in 26. Now, if you have, after your repair, a residual mitral dysfunction, what you do as a surgeon, because if it's not good, it's not going to get better, is my philosophy. You have, with your cardiologist, echocardiographer, estimate the volume of the regurgitation. You have, try to identify what is the mechanism and location of the residual defect. And then you have, to ask the question, if you can do better. If you have, the impression that you cannot do better, is better, to accept, to do a compromise and to accept, some residual stenosis and regurgitation. Because here, we have to be, to agree on the fact that especially in the dysplastic leaflets where there is a lack of valvular tissue, repair is palliative or semi-palliative. And the main target here is to buy time in order to be able, to put later on a larger mechanical prosthesis. But repair is durable in the majority of cases with pure congenital mitral insufficiency. When you do this kind of repairs, avoid procedure preventing the growth of the annulus, and for it is then go to the biodegradable options, then to the use of traditional rings, and avoid additional procedures leading to technically complex operations to treat residual lesions with a prohibitive high risk, and for it is then don't lose time. And be in favor of the compromise. Thank you.
So, unfortunately, the next speaker, Dr. Dizdarevic, cardiac surgeon from Belgrade, who should be the next by Zoom presentation, he just canceled a few minutes ago. So we have on.
I can present the rheumatic valve, because otherwise I will give my key. No, not our key, because here, we were supposed, to present the rheumatic mitral valve. Or you would like to?
No, we can use the time for discussion.
For discussion, okay. Then I have, again, the great pleasure to present the last speaker.